Okay, Assalamu alaikum. Today we will present postoperative pain management in ICU. The presenter will be Dr. Sharif Abdulrahman. He's the registrar of General Anesthesia, Sudan Medical Specialization Board.
Assalamu alaikum. Bismillah. We'll start, inshallah, to talk about postoperative pain management in intensive care unit. Okay. We have a question before we start. What assessment tools do you use for assessing these patients' postoperative pain? Other question: are your tools appropriate if your patient's mental state altered?
سوري شريف معلش بس في ايكو انت فاتح تو جهازين اثنين.
What are the benefits of treating pain in ICU, and what are the risks of not treating this pain? An ICU order has been mistakenly administered bupivacaine IV instead of giving it in the catheter. What are your immediate and subsequent actions? Describe the last protocols. What are other pain management modalities do you use if the catheter is not functioning? Okay, we have key points to talk about. Pain is a common problem in intensive care. Regional anesthesia offer excellent pain relief while avoiding opioid-induced side effects. Performance of regional anesthesia in intensive care is challenging. The pharmacology of local anesthetics is greatly influenced by pathophysiological states in ICU settings. Sepsis, coagulopathy, inotropes, dependent, and sedation. Risk benefits of regional anesthesia must be considered on the individual basis. A high index of suspicious and close monitoring to development of neuraxial infections or local anesthetic toxicity. The risk due to regional anesthesia can be minimized by adopting local and national guidelines using modern technologies and considering available alternative and local expertise. Okay. Patient in intensive care experience distress because of multitude of factors and significant proportion is attributable to pain. A vast majority of patients report moderate to severe pain at some point during their intensive care stay. Pain can be caused or provoked by many pre-existing conditions. Acute medical, surgical, routine aspect of intensive care. Pain is widely regarded as a fifth vital sign, and it induces a myriad of deleterious physiological changes in most organ systems. Severe pain induces stress response and sympathoadrenergic stimulation cause tachycardia, hypertension, increased myocardial oxygen consumption, can induce myocardial ischemia in susceptible patients. Causes of pain in intensive care, we have many causes. We have two types of causes. We have constant background pain and we have intermittent or procedural pain. constant background pain requiring infusion of opioid adjuncts, post-operative like surgical incision, abdominal chest drains, pre-existing, like exacerbation of chronic pain, arthritis. We have other neurological conditions which cause pain in intensive care, like phantom limb pain, spinal cord injury, demyelinated neuropathy, Guillain-Barré syndrome, multiple sclerosis. We have traumatic cause of pain like amputations, fractures, soft tissue injuries, pain, pressure sores. Okay, other cause, second cause, we have intermittent procedural pain requiring bolus of opioids and adjuncts. We have other causes like invasive procedure, central and arterial line placement, tracheal tube, nasogastric tube, catheters. Routine care and routine care can cause pain in intensive care, like position change, physiotherapy, tracheal suction, and mobilization. All this can cause pain inside the intensive care. Okay, we need to come to talk about the effect of pain in the general system in the body, deleterious effect of pain. In the cardiovascular system, the pain, severe pain induce a stress response and sympathogenic stimulation cause tachycardia, hypertension, increase myocardial oxygen demand, and can induce myocardial ischemia in susceptible patients. In the respiratory system, the effect of pain was poorly managed pain from abdominal incisions, reduced diaphragmatic function, cause hyperventilation and atelectasis, which is main complaint, and need to go to use mechanical ventilator in ICU. Psychological cause of pain, psychological effect of pain, and agitation, delirium, post-traumatic stress disorder, depression, and anxiety, and chronic pain, especially in sedated patients. Okay, systemic deleterious effect of pain include systemic inflammatory response syndrome, hyperglycemia, immunosuppression, impaired wound healing. Okay, impaired wound healing of the cause. Impaired wound healing, hypercoagulability, catabolism, increase catabolism. All these detrimental effects can lead to increased length of intensive care stay and hospital and mortality. Despite overwhelming evidence of adverse clinical impact, pain remaining frequently assessed and poorly managed in ICU. My voice is clear? Is my voice clear?
Yes.
Okay. Benefit of managing pain as general, patients who had regular assessment for pain are more likely to have lighter level of sedation and increase in use of non-opioid multimodal analgesic therapy and preemptive analgesia before painful procedures. This effect has been shown to decrease the duration for mechanical ventilation and ICU stay. There are numerous barriers to pain management in the ICU, and surveys have relieved wide national and international variation in assessments, monitoring drugs and protocols and algorithms used for sedation and analgesia. Okay, patient evaluation. We have now a diagram, important diagram to assess, to evaluate a patient's pain. We have three types of pain. We have high pain, moderate, and low pain. In the high pain, like major trauma or surgeries, multiple pain issues, chronic opioid use. In the high pain, high type of pain, as for medium risk, we can do nerve block if there is no contraindication, preoperative consideration, like gabapentin, melatonin IV or IV regional NSAIDs, alpha-2 agonist like clonidine, consider and consult acute pain specialist, or continuous postoperative catheter. I mean here, epidural catheter, nerve block catheter. This is in the high pain, high level of pain. In the medium pain, this will be bone-related surgery, from pain-related surgery, mild pain history, modest chronic opioid use, young patients. As low risk people consider long-lasting anesthesia method like nerve block. Here we can do first line NSAIDs, acetaminophen, opioids, drug like codeine, tramadol, and hydrocodone. Second line, stronger opioid, oxycodone, consider IV NSAIDs like ketorolac. And the third type of pain, which is low pain, minor, it come from minor or soft tissue surgery. Here, there is no major pain history, no chronic opioid use, can occur in elderly people. Here, first line is acetaminophen, second line at per orally NSAIDs, oral NSAIDs, per oral. Third line, weak opioids, combo drugs, codeine or acetaminophen. Pain assessment. This is one of the important issues because we have a problem in the assessment of pain and in the intensive care unit. Recognition of pain in ICU. Recognition of pain in ICU patients is the important first step in its management. Verbal reporting is not always possible because of difficulties in communication, sedation, delirium, and tracheal intubation, and patient will be on neuromuscular blockade and weakness. This is all cause of difficult to assessment pain in ICU. Here we talk about pain scale, pain score. Self-reporting of pain is considered as gold standard, and wherever possible, healthcare professionals should try and rate patients' self-reporting pain using validated scales. We will talk about this scale. Pain scales can be continuous or discrete, unidimensional or multidimensional, the subjective or objective. Commonly used pain scales in the ICU are unidimensional and are quite useful in the assessment of pain and measuring response to treatment. Recognition of pain in ICU. We have physiological parameters which are usually related to pain, can be caused or masked by various other factors in ICU setting, like arrhythmia, sepsis, inotropic therapy, beta blockade, other pharmacological intervention. This is always good masking to the to the pain, which will affect the assessment way and recognition of pain in intensive care. Less than 50% of intensivists and intensive care professionals assess pain, and even when done, it is only done infrequently. Lack of training in the assessment of pain is a frequent cited factor for poor pain management in intensive care. The main principle of pain assessment in the critical ill are to understand and identify the cause of distress, most common but not all, of which is attributable to pain. Assess pain, sedation, and delirium using validated scales regularly and accurately, and use all information in conjunction. Vital signs should not be used alone in the assessment of pain, but may be used as a cue to being further assessment. We cannot assess pain by vital. I cannot say this tachycardic patient does mean he will have high pass score or high degree or high scale of pain. Pain scale for patient able to communicate. We have this one type of pain scale for patient able to communicate. We have a visual analog scale, VAS scale, which is a common scale, and many people know about it. Visual analog scale, VAS scale, patients mark their pain on a 100 millimeter line with verbal descriptors at each, and 0 means no pain, 100 very severe pain. This score is obtained by measuring the distance in millimeter from the left end of line. We have numerical rating scale in RS. Patients rate pain on 11-point scale. 0 means no pain, 10 means severe pain. We have verbal rating scale, VRS, 4-point scale in which the pain can be rated as 1 absent, 2 mild pain, 3 moderate pain, and 4 severe pain. We have also verbal rating scale. Okay, this is a VAS score or visual analog scale, visual analog score. Patients mark their pain on a 100 millimeter line with verbal descriptors at each end. You see the diagram, 0 mean no pain, 1, 2 mean mild, 3, 4 mean moderate, 5, 1 means 6 means severe, from the 4 to 6 mean severe, 8 7 mean from 7 to 9 mean very severe, and 10 mean worst pain. The score is obtained by measuring the distance in millimeter from the left end of the line. This is numerical rating scale, NRS. Patients rate pain on an 11-point scale. 0 mean no pain. 10 means severe pain. Sorry. طيب. Verbal rating scale, 4-point scale in which the pain can be rated as absent, 1, 2, mild, 3, moderate, 4, severe. Pain scale for patient unable to communicate, which is very important because many of the patients in ICU are able to communicate, sedated or in mechanical ventilator. Okay, behavioral pain scale. This scale uses clinical observations of facial expression, upper limb movement, and synchrony with mechanical ventilation. Behavioral pain scale range from 3 to 12. Score more than 6 require pain management. Behavioral pain scale. Okay, I think this is like GCS. one of the problem. واحد من المشاكل في انا ما يعني السكور بيستخدم عاده في الاي سي يو والجي سي اس. ف one of the neglected issue score of pain in the intensive care. Okay, this scale, this behavioral pain scale depend on facial expression, movement, upper limb, and mechanical ventilation. Facial expression, if patient relax, will score 1. Partially tense, score 2. Totally tense, 3. Grimace, 4. Movement of upper limbs will relax, 1. Partially flex, 2. Totally flex, 3. Totally contract, 4. Mechanical ventilation, tolerating movement, score 1. Coughing but not tolerating most of the time, score 2. Fighting the ventilator, score 3. Impossible to control ventilation, score 4. Behavioral pain scale for intubated patient. When patient relax, we will give him 1 according to facial expression. Patient relax, 1. Partially tightness, 2. Fully tightness, 3. Grimace, 4. Movement of upper limbs, if there is no movement, 1. Partially bent, 2. Very bent with finger flexion, give 3. Retracted opposite to care side, 4. By mechanical compliance with ventilator, tolerating to ventilator, give 1. Coughing but tolerating verbalization, most of time giving 2. Fighting ventilator but sometimes ventilation but fighting ventilator, sometimes giving 3. Unable to control ventilation, giving 4. This is for intubated patients. For non-intubated patients, same issue. Here patients relax, give 1. Partially light, tight, 2. Fully tight, 3. Grimace, 4. Pain is common cause of distress in intensive care unit, and the vast majority of patients experience it at some point during a stay. The vast majority of patients experience it at some point during their stay. Systemic analgesia, most notably opioid, remain the mainstay in its management. Opioids are associated with significant side effects like delirium, ileus, respiratory depression, and increased duration of mechanical ventilation, especially when used as continuous prolonged infusion. There has been a general trend in ICU to move toward target analgesia and avoidance of sedation. In the ICU, regional anesthesia, when indicated, has the potential to offer excellent pain relief, but avoiding the unwanted side effect of opioids. unlike the preoperative setting, its role in the ICU has not been thoroughly evaluated. However, the potential benefit of a biregional anesthesia can be significant and extend beyond just provisional of analgesia. Despite its numerous advantages, regional anesthesia remain underutilizing modality due to various challenging and perceived disadvantages. We will talk about advantage of regional anesthesia in intensive care. It will provide excellent pain relief, reduction in stress response, reduce sedation delirium, reduction in use of opioid and their side effect, reduce sedation delirium and illness, ability to better assess neurology in the absence of opioid, especially polytrauma, possible reduced duration of mechanical ventilation and early ambulation, minimize progression to chronic pain, example in amputation, promote gut motility and splanchnic perfusion, reduce sympathetic tone useful in promoting blood flow and critical ischemia. اخوانا معايا صوت واضح؟ الو الحضور ماله في الناس حاضره في الاونلاين اكتر ولا شنو؟
Yes, in Facebook.
Facebook, okay. Disadvantage of use of regional anesthesia in intensive care: need for expertise and high resolution ultrasound machine, variable failure rate, difficulty in obtaining consent, possible but unproven higher incidence of rare and serious complications like epidural hematoma, difficulty monitoring for side effect in sedated patients like nerve injury, repeated position change leading to the dislodge and disconnection of the catheters, potential for error and root and drug. We have a specific challenge in intensive care. Regional anesthesia in ICU settings possess unique challenge, which can be divided into drug factor, patient factor, human and environmental factors. Drug factor will talk about local pharmacology, local toxicity, and local anesthetics path. Okay, we should to speak about pharmacology of local anesthetics. The pharmacokinetic and pharmacodynamic of local anesthetics may be altered due to the arrangements in physiological and metabolic parameters commonly seen in intensive care unit patients. The arrangement in acid-base balance, hypoalbuminemia, and organ failure, hepatic and renal influence the ionization, unbound free fraction, and distribution of the local anesthetics between body fluid, the arrangement acid-base balance, hypoammonemia, and organ failure, hepatic and renal influence the ionization, unbound fraction, and distribution of local anesthetic between body fluid compartment and their clearance. The impact of these dearrangements may be subtle like prolonged onset and duration action, or dramatic like local toxicity. To factor these adjustments to the choice and dose of local anesthetic may be needed. The degree of ionization of a local anesthetic depends on difference between its dissociation constant pKa and the pH in the tissues. As local anesthetics are weak bases and have a pKa higher than physiological pH, they exist predominantly in the ionized form in an acidic environment. As only the unionized form is lipid soluble and hence can cross the cell membrane freely, onset of action will be delayed in both local, example abscess, and systemic septic shock, renal failure, acidosis, hypoalbuminemia, which is commonly found in acutely ill patients, increase the unbound free fraction of the local anesthetics and can be increase the risk of local anesthetic toxicity. This is important issue. We need to know what is local anesthetic toxicity. It's impaired ability to clear local anesthetic due to factor discussed above predisposing to local anesthetic toxicity, especially when administered in large doses as prolonged infusions. Cardiovascular collapse or seizures may be the only sign, especially in sedated patients, and hence high index of suspicion. is necessary. Recommended maximum ropivacaine dose of 2 mg per kg over a 4-hour period and 400 mg over 24 hours. For ropivacaine, depending on the site of injection, the maximum recommended bolus dose varies between 200 and 300 mg. And when used as an epidural infusion, can be given up to maximum of 28 mg per hour, cumulative dose of 675 mg over 24 hours. The maximum allowable local anesthetic dose should be calculated on the basis of ideal body weight with adjustment for organ impairment. The use of adjuvant opioids, clonidine, ketamine, epinephrine, and dexamethasone allow for a reduction in the dose of local anesthetics. In the case of epinephrine, also reduce the plasma concentration. Everyone should have a protocol for management of local anesthetotoxicity and use of intralipid rescue. Maximum safe dose of lidocaine with epinephrine 7 mg per kg, without epinephrine 3 mg per kg. Bupivacaine with or without epinephrine 2 mg per kg is the maximum safe dose. Patient risk factor. Owing to these changes, it is reasonable to assume that regional anesthesia technique may run a higher risk complication like failure, infection, bleeding, neuronal injury, pneumothorax, and hemodynamic compromise. In addition to the development of complication is likely to have a greater impact on the recovery. And rehabilitation of the patients, prolonging their stay in intensive care. As an example, diaphragmatic paresis from intrascalene block in patients with chronic obstructive pulmonary disease may hamper successful weaning from ventilator support. Immunosuppression is very common in intensive care unit, either due to pathological insults or pharmacological interventions, sepsis, steroid, drug-induced side effect. This is not only increase the risk, but may also mask the typical signs and symptoms for axillary infection. High index of suspicions and regular monitoring for rare complication of regional anesthesia like meningitis, vertebral abscess, epidural and subdural hematoma, and local anesthetic toxicity is required. Daily nursing observation should include monitoring of neurological function and checking the catheter insertion site for sign of infection. Organ dysfunction, like renal failure and uremia, can result in hyperdynamic circulation, resulting in rapid absorption and higher peak plasma concentration. This, combined with lower plasma clearance, of local anesthetics, may lead to sustained high plasma concentrations. Hence, a 10 to 20% dose reduction relative to the degree of renal dysfunction is recommended in situations where a high bolus dose, example brachial plexus and paravertebral block, or prolonged continuous infusion techniques, or where repeated bolus block less than 5 half-life are needed. Marked derailment in physiology can occur, include coagulopathy, increased volume distribution, reduced plasma clearance, hyperdynamic circulation, and concomitant renal dysfunction. Usually, local anesthetic dose not to be decreased for single shot techniques. Does need to be reduced by 10 to 50% for continuous infusion or repeated bolus block less than 5 half-life, depending on the extent of the hepatic and renal dysfunction. The low cardiac output state result in reduction in hepatic and renal clearance of the drug. Therefore, local anesthetics with high first pass metabolism, example lidocaine, may reach a high plasma concentration. In contrast, strongly protein-bound drugs like ropivacaine and bupivacaine have a relatively low first pass metabolism and hence are not greatly affected. In the presence of advanced heart failure, dose reduction to the order 10 to 20% is recommended. In the presence of advanced heart failure, dose reduction to the order of 10 to 20% is recommended. Also, epinephrine should be avoided as an additive to local anesthetic in this patient due to the risk of arrhythmias. Human environmental factor, lack of opportunity for training and familiarity among the nursing staff, and increased risk of human error. Using non-interchangeable connectors in the regional anesthesia reduce the chance for drug errors or local anesthetic toxicity from a different IV infusion. Increased risk of catheter dislodge due to repeated change in position for routine aspect of intensive care, and to aid oxygenation. Tunneling catheters intended for long use and securing the connectors firmly with specialized tunneling catheters intended for longer use and securing the connectors firmly with a specialized device would mitigate this risk. Other environmental factor like space constraints, examining dwelling drains, lines and tubes, ICU equipment, and availability of necessary regional anesthesia equipment can also be impeded. Management of pain. Principle of pain management in intensive care unit. The basic principle in management of pain in intensive care unit are very similar to the preoperative setting, ensuring a holistic approach to pain management by using combination of non-pharmacological and pharmacological interventions, systemic analgesia, and local regional techniques. Using a multimodal approach to management of pain to improve the quality of analgesia and reduce side effects. The important modifications are emphasize on analgesia before sedation, analgesia first, and daily plan interruption of sedation. Consider distress because of anxiety and delirium after pain has been adequately managed. Titration of analgesia to specific individualized goals with the assessment and avoidance of continuous prolonged infusions. Understanding that drug can cause organ dysfunction, and organ dysfunction can influence the choice of drug and dosage, needing individually adapt analgesic regimen. Greater use of sedation, pseudo-analgesia is associated with cardiovascular depression, increased duration of mechanical ventilation and intensive care stay, delirium and cognitive dysfunction. Algorithm emphasize adequate analgesia before sedation, analgosedation or analgesia first, reduce the requirement for sedation, duration of mechanical ventilation without increase the incidence of accidental extubation or post-traumatic stress disorder. Okay, this is article, one of the article. Talk about preneural versus intravenous dexamethasone. طيب here احنا هنا يا اخوانا بنتكلم عن ال preneural dexamethasone. يعني this is other plan of management in intensive care. Preneural dexamethasone mean use sonoplex needle or blood needle, which is a safe needle to the nerve. هي متوفر يعني في عدد من الشركات. السونوبلكس needle دي can inject the nerve without make injury in nerve. This is يعني بالذات يعني one of the companies like B Brown company هنا عندهم السونوبلكس needle دي. فأنا when I take this needle to do preneural dexamethasone, it very يعني high success rate of treated pain. فهنا بنتكلم عن preneural versus intravenous preneural versus intravenous dexamethasone as an adjuvant for peripheral nerve block. At conclusion of this study, our results show that preneural dexamethasone can prolong the effect of analgesics duration when compared to intravenous route. يبقى هنا ده يعني احنا use of peripheral nerve stimulation in intensive care will lead to a new side of management of pain when I giving drugs neurally, pre-neural. ممكن اللي قدامي يظهر والله برينيورال بيسيدين ممكن يكون طبعا دي حاجه كلها في اسمها يعني طور الاستادي، ده كلام جديد يعني في الانتنسيف كير او في البين مانجمنت عموما او في الريجونال انستيزيا. when I given drugs برينيورال drugs ديكساميثازون. فاي هوب انه الناس لو اشتغلت في الحاجه دي they will come to يعني get a good result. Indication of regional anesthesia in intensive care unit. The indication for performing regional anesthesia in intensive care are likely like the pre-operative period, and in many cases is only quantum. بمناسبة البرينيورال ديكساميثازون دي يعني قبل فترة كان عندنا محاضرة وهي she doing dressing continuous regular dressing for her wound. She refused to get spinal anesthesia. طبعا الانستيزيا is يعني according to patient wishes، يعني patient من حقه انه يرفض انه to accept or to refuse. She refused spinal anesthesia. We try to do, or already we do perinatal dexamethasone for her, dexamethasone on sciatic nerve, sciatic dexamethasone perinatally. It will give her very imaginary results. يعني البيشنت كان مبسوطة جدا والدريسنج ماشي تمام وأمورها كانت يعني الحين الأمانة عملنا لها اللي هو sciatic nerve block by بلامركان بلس دexamethasone اللي هو هنا برينيورال دexamethasone. فالبيشنتس يعني مشت البيت وامورها كانت تمام و she have 2 days free of pain and continue her dressing smoothly. The indication of performing regional anesthesia in intensive care are like the preoperative period, and in many cases is only quantum. For example, thoracic epidural analgesia facilitate early weaning from ventilator support in lung surgery, lung transplant, and thoracic trauma. The medical and surgical conditions which are specific to ICU which benefit from regional anesthesia are summarized in the table below. طيب التيبل ده very important. هنشوف الانديكيشن for regional anesthesia، هنشوف الكونديشن شنو، ونشوف التكنيكس. For thoracotomy example عندنا surgical indication thoracotomy, lung transplant, and lung resection. What is best regional analgesia technique for this patient regional anesthesia? We can to do thoracic epidural, we can to do paravertebral block. This is 2 chance for thoracotomy, lung transplant, and lung resection patients. Okay. طيب بالنسبة لللابروتومي we can do neuraxial epidural spinal, we can do lap, tap, block, classical and subcostal approach, rectus sheath block, local infiltration, analgesia. In the rib fractures, we can do thoracic epidural, paravertebral block, intrapleural block, intercostal block, and serratus anterior plane block. In the lip fracture, traumatic or pathological, plus amputation, we can do lower limb. If fracture or amputation in the lower limb, we can do spinal, epidural, plexus, lumbar and sacral, facial plane block, facial iliaca block, and peripheral nail block. femoral, sciatic popliteal زي ما يعني قلت لكم في البيشنتس اللي عملنا لها. upper limb, we can do brachial plexus block and peripheral nail block. Okay. In the non-surgical condition like acute pancreatitis, we can do thoracic epidural, celiac plexus block. طبعا celiac plexus block very important procedure, regional anesthesia procedure we can, or regional anesthesia block we can do for the patients, especially patients of malignancy. Brachial plexus, celiac plexus block we can to give more than 2 months free pain. One of the important practice in the oncology centers. يعني هاي للاسف احنا فاقدينها هنا. يعني البيشنت هنا we going to oncology centers, there's no any pain management or any palliative therapy regarding a pain for patients on malignancy. Okay, we have neurological complex pain syndrome and ischemic limb. We can to do hemolytic block. In the procedure in intensive care, in the chest drain, we can do intercostal block. Tracheostomy, we can do superficial cervical plexus block. Debridement, dressing change, we can do upper and lower limb blocks. I think this is a procedure when we try to do it in the intensive care, we can to limitate the movement and of the patients from the intensive care to theater. If we can prepare a sterile area around the patients, we can do fixed chest tube inside the intensive care. Okay. Okay, we have here case study. Talk about brachial plexus block, low ejection fraction patients. Okay, case study. طيب, sorry, questions. Let us to speak after. احنا ممكن نجاوب على أسئلة post session. Okay. Question will answer post session. Okay, our case study. This is patients that come to us in the operation in the theater. 70 years old male, admitted to us 2 weeks ago, presented complaint of painful hand and pulse discharge from his wound. He has a heart failure due to acute coronary syndrome. Ejection fraction was 35 on anti-ischemic drugs. Has AKI, electrolyte disturbance, sepsis due to right forearm abscess, tachycardic tachypneic. Patients have 3 times postoperative, زي ما موضح في عفوا 3 times postponed because he have low ejection fraction. Here our anesthetic plan, our anesthetic chance restricted because we know propofol is cardiodepressive drug for these patients. I select our plan, anesthetic plan for these patients. We do brachial plexus block auxiliary approach. We have a block radial, ulnar, and median nerve block by 10 ml, plain Marcaine, or bupivacaine hydrochloride for each nerve. 10 ml superimposed in auxiliary sheath patients, and co-patients accept to publishing this case. I will على دي فيديو I will see يعني نشوف الحاصل شنو في الثياتر. فالحمد لله البيشن ويجيب يعني انترسياتر بهاي ريسك كونسنت والامور ماشيه تمام. والبيشن get postoperative pain for more than 24 hours, going to ICU. No need for, it was free of void anesthesia, no need for any analgesia like pethidine or any drug. We have to have fixed nerve catheter for these patients. طلع بعمل السياتر. Okay. This is our patients here. This is our position for his huge wound. This is the wound. I think this is الwound. طبعا huge wound يعني في الاريا. ان البيشن هنا الراديال انر كل النيرفز الميجر في الابر ليمز خاشه معايا او انترين في الاريا دي. طيب هنا نشوف موضحين لنا في الصوره هنا. طبعا دي from نيسورا Neuro Society for Regional Anesthesia ويب سايت. indication of axillary block في الفور arm hand surgery. الألماح حقتنا هنا الاكسيلري artery pulse. check الاكسيلري artery pulse like central line detection. هناك detect femoral artery, هنا you detect الاكسيلري artery. any following this technique طبعا هو النيرف بلوك ultrasound guided or nerve block guided, nerve stimulator guided. هنا we use nerve stimulator guided. Okay. Hand which is 0.3 to 0.5 milliampere current. Then patients after that we can't inject every nerve. He have a specialized movement with the nerve stimulation. The axillary block. دي الألمار حقتنا. This is our hallmark. This is axillary artery. ممكن detect the surgical pain. 2 o'clock we will find here a median nerve. Need to inject here. 5 o'clock we found ulnar nerve. We need to inject ulnar nerve in this hand on these patients. Radial nerve. 8 o'clock we can to inject plain Marcaine or bupivacaine hydrochloride in this area, 10 ml. We can dilute it by muscle line. We can add dexamethasone, like I say, pre-neural dexamethasone for prolongation. This is innervation site, radial nerve, median nerve here, ulnar nerve. Musculocutaneous not needed on these patients. Okay. If I do ultrasound guide, the ultrasound for the axillary area for the patient, the axillary artery, we insert a needle here, and here the median nerve, ulnar nerve, radial nerve. We should inject in each nerve. Avoid to injure the axillary artery. Ultrasound guided nerve block. This is the needle. You can't see. Okay. This is our procedures. This is blame marking, this is nerve stimulator, sterile gauze, syringe. These landmarks, we should to use surgical pen to determine axillary artery then above and below axillary artery, 2 o'clock, 8 o'clock, 5 o'clock, like previous I mentioned. Okay, now I will see you and videos of the operation. Okay, this is operation. This is inside operations. نجد هنا في الفيتال ساين لو لاحظنا respiratory rate 16, blood pressure, patient vitally stable. There is no pain, there is no any problem with the patients. See here, patients not intubated. That means our block was success. Dressing was gone smoothly with no problem. This is example of one of the benefits of regional anesthesia in critical patients. Breakable access block, axillary approach. Patient accept to publishing his case for educational purpose. Okay. Regional anesthesia in intensive care. To minimize the risk of regional anesthesia by availing best local expertise, avoid multiple needle pulses using advanced technology like ultrasound or nerve stimulation. Appropriate case selection, consider available alternative, meticulous monitoring for complications. Okay, this is important. Sure, we'll talk about last protocol. If you are doing inject intramural local anesthetic, or you are inject more than the maximum, you will provide local anesthetic to the patients. This is our guidelines. Stop injection, call for help, last rescue kit, start ventilation support, cardiovascular support, seizure control, alert cardiopulmonary bypass team. Okay. About ventilation support, we used to ventilate patient with 100 oxygen, avoid hyperventilation, advance airway if necessary, control seizure, benzodiazepine prepared, avoid large dose of propofol. Lipid emulsion therapy, therapy of lipid emulsion. If patient more than 70 kg, give him bolus 100 ml of lipid emulsion over 2 to 3 minutes. If patient less than 70, if the patient less than 70 kg, give him bolus 1.5 ml per kg over 2 to 3 minutes. Right, this is bolus. Or by infusion, if patient more than 70 kg, give him infusion 200 to 250 ml over 15 to 20 minutes. Or if patient less than 70 kg, infuse 0.25 ml per kg per minute, ideal body weight. Then reassess. If patient remain unstable, rebolus once or twice, same dose and double infusion rate, dosing limit 12 ml per kg. This is the last guidelines about how to deal with last from NYSURA, New York Society of Anesthesia. Recommendation for performing neuraxial block in the presence of sepsis. Epidural catheters should be removed in the presence of local erythema, discharge, or both. There are no convincing data suggest that concomitant infection at remote site or the absence of antibiotic therapy are risk factor of infection. Close monitoring of neurology and sign of local infection at the injection site may help in early diagnosis, especially when epidural catheter in situ for more than 48 hours. Delay in diagnosis and treatment of major central nervous system infection of even a few hours may significantly worsen neurological outcome. Okay, here the nerve block from the higher to lower. And the normal risk, we have normal risk في local infiltration. More شوية كده superficial block, forearm nerve block, saphenous nerve block, atney, nerve block at ankle, superficial cervicalis, plexus block, wrist block, digital nerve block. This is more risk. Higher risk here, epidural with catheter and single short epidural spine paravertebral block. This is the higher risk. Okay. There is some issue talk about unconscious and sedated patients. Consent for regional anesthesia in ICU is no different from these other procedures and should be considered if the benefits outweigh the risk. Many anesthetists prefer to perform regional anesthesia in awake patient and would not perform it in anesthetized patients. هنا كلير يا اخوانا؟ الو
Yes, clear. Yeah.
السكرين واضحة؟
واضحة.
Okay. We have a special consideration when we talk about laparotomy. Laparotomy is one of the most surgical reasons to admission to ICU, and until recently, only thoracic epidural anesthesia was the commonly used regional anesthesia technique to provide pain relief. Thoracic epidural anesthesia does not reduce mortality when compared with systemic opioid, but has a favorable influence on the numerous morbidity factors, reduction in the incidence of paralytic ALS, delirium, and duration of mechanical ventilation. Trunk block when compared with opioid-based technique offer equivalent analgesia, but with quicker recovery of bowel function. It is important to understand the anatomy to choose the most appropriate technique for the patients. Rectus sheath block are effective in providing analgesia by blocking the anterior cutaneous nerve of the abdomen. Top block, unlike rectus sheath block, are effective for transverse incision, but are inadequate for covering dermatome above T10 level. Variant of top block, the subcostal oblique top block, can be used for incision above the T10 dermatome. For example, rooftop incision for cholecystectomy and liver resection. A retrospective study, top block were as effective as thoracic epidural anesthesia for open abdominal aortic aneurysm repair. Type this top block technique, this is below ultrasound. And الفكرة حاجة top block, we have 3 layers in abdomen, external oblique layer, internal oblique layer, a transverse abdominis plane. We have ultrasound guided or PNS guided. Here we النيدل دخلناه هنا between the transverse abdominis layer and internal oblique. We inject in this whole area. Will provide anterior abdominal wall analgesia. There's many indication of top block, especially in lower abdominal surgery and C-sections. It will provide C-section without pain for pregnant ladies. She can't mobilize post-operative and start lactating her baby, and there is no problem with, there is no pain ever. One of the pain relief procedures or regional anesthesia technique we can to provide for these operations. Acute pancreatitis is a very common surgical emergency with an annual incidence of 15 to 35 per 100,000 and with mortality up to 30% in severe types. It associated with severe pain and opioid-based strategy remain the mainstay of analgesia. However, opioids can cause or worsening ileal sedation and reduced respiratory drive, which may be detrimental to these patients who generally present with multi-organ impairment. There has been inertia for adopting thoracic epidural anesthesia as a normal component of pain management in acute pancreatitis. even those there have been successful report dating back to 1950. This is Sonoplex, bionic Sonoplex needle. This is a magic needle, which is blunt needle we can't use to inject nerve perineurally and to do nerve block as general. The properties of this needle, the blunt needle, are manufactured with the blunt tip to minimize the risk of tissue and nerve damage or articular uptake. This design may reduce the complication of treating acute and chronic pain, such as intra-arterial or intraneural injection. This needle features a CODI or straight, atraumatic distal tip, circular side opening for maximum flow rate, depth marking, and printed arrow on hub indicating direction of the curve of infusion and infusion port. I'll marking the in the ultrasound, it will be clear, easy to identify, it facilitates identify the needle below ultrasound. Okay. It is important of ultrasound to use ultrasound in the practice in intensive care and the regular anesthesia general. This is one of techniques, in-plane technique or out-of-plane techniques. This techniques used to identify or to found the nerve below the prop of ultrasound. This is approach, out-plane approach, in-plane approach. This is a wireless ultrasound. We have used it to identify. This is a trial to identify axillary nerve below by using wireless probe. I think the quality of the probe is good here. You can connect in the iPad or in the tab or in the phone by wireless. One of the important procedure and technique we need to use it. Conclusion: pain is a common problem in intensive care and remain poorly assessed and managed. Pain adversely affects multiple organ systems, and inadequately managed pain has a direct impact on outcome. When managing pain, emphasis must be placed on regular assessment and using protocol-based multimodal analgesic regimen. The decision on the choice of the analgesic drug must take into the account the pathophysiological derangement that can also occur in intensive care unit, and also potential for these drugs to cause organ damage. I have recommendations here to conduct a clinical audit about pain management in intensive care. The adult is distributed to consultants, specialists, residents, medical officer, nursing staff. We can do audit about pain assessment, pain score, medications, local anesthetics, local anesthetic catheter, to train ICU staff on different pain equipment, especially the catheter of local anesthetics. For local anesthetics, if they are connected IV, they would have a fatal outcome. To provide the intensive care unit with cutting-edge technology and up-to-date analgesics like PCA machine, patient control analgesia. Here, patients control to provide analgesia to himself by this handle. It's clear in the picture. Infusion pumps, this handle. Infusion pumps, syringe pumps, TCI machines, remifentanil, alfentanil, to adopt our own guidelines and policy and our own pain scores to create an excellent rapport with other specialties involved, psychiatry, anesthesia, and neurology in pain. In pain, like anesthesia, psychiatry, and neurology, special focus on patient at risk developing pain patient, pancreatitis, and other surgical patients. Thank you for your attention.
There is a question from Dr. Vladimir in chat.
Okay. You are welcome, Dr. Vladimir. You can to ask. Yes, we have used it. Actually, I use it 1 or 2 times with sciatic nerve block mixed by bupivacaine hydrochloride for ladies, for elderly women with bring to us for debridement of her wound in lower limb. It was amazing result. Prenatal dexamethasone, there is different from IV dexamethasone. It will prolong the duration of the block. This lady she have 2 days free of pain when I use dexamethasone for her preneurally. Yes. Yes. Any question?
Yes, may.
Welcome.
Dr. Awatif. Hello, everyone. Thank you, Sharif, for this excellent presentation. Actually, I haven't used any dexamethasone with any of my patients before, and I don't have an experience of its use either to prolong the nerve block or to increase the intensity of the block. I don't have an experience in that, but definitely I'm going to try it from now on. The other thing that I want to emphasize that regional anesthesia nowadays, with the current situation in our country, we have very deficient general anesthesia drugs, and sometimes we have to cut in the use of these drugs so that we can minimize the use of general anesthetic drugs as much as we can. So regional anesthesia is a very great choice for many patients, and it can be used with general anesthesia for analgesic purposes, برضو, like tap block, regional blocks, whether it can break a plexus or lower limb blocks, can be used with general anesthetics. As we know, we have, on these days, we have lack of opioids in the country. So everyone have to know how to do regional blocks. The way you use it, I learned from you to use it by landmarks. I started regional blocks by ultrasound, but you taught me how to use landmarks. It is very nice and very safe, and everyone can do it. I have an experience of using spinal needle, 22 gauge, the black one, for regional blocks. For me, it is, they think that it might hurt the nerves because it's sharp. It might hurt the nerve. But for candidates who are training and who are still first time using the needles and first time doing the blocks, using a big gauge needle sometimes with unexperienced might have problems in the injuries for veins and arteries. But by my experience, I think it's safe to use just simple needles. And if the patients complain of any neural pain, or the patient has any sensation of any electrical impulses in the limb, you just can withdraw the needle few millimeters and then inject the local anesthetic. Just an experience review for all. Thank you, Sharif, again, and open for any next questions.
May I comment? Assalamu alaikum. Well, I'm not surprised to see Sharif as the first registrar to present, and I'm so glad, and you did an amazing job. Thank you, Sharif. To be honest, what I want to reflect is in our practice in ICUs, it's common to see many patients in pain, and unfortunately, some of them are sedated, even what you call muscle myorelax, and like they are crying. You can see tears in their eyes from the pain, and this is not accepted practice. So please always remember, pain is a duty of an anesthesiologist and intensivist. Pain should be treated as soon as possible because it alters the outcome and change a lot, and this is your responsibility. So such practice in ICUs is not accepted no more, and it's counted as a malpractice, to be honest. Second thing, Post-operative management include post-operative pain management, and that should be part of your planning. When you go to any procedure, when you have time, try to think if you will use combined technique, for example, general anesthesia plus regional blood, or for example, epidural, when you have time, because this will alter the outcome. It will enhance the recovery. It will cut days of ICU admission, save money, save time, and save the patient. Multimodal analgesia should be started intraoperatively or even, like preemptively. You can start the drugs or you can start some of the medication, for example, non-steroidal anti-inflammatory drugs before the operation even. And this will cut the dose that you need of opioids, because now internationally we have an opioid pandemic. Everyone is fighting opioids. So after some times, I think we have to start cutting. Besides the current situation in Sudan, we are out of opioids, unfortunately, and we are so I think we need to work on regional techniques, and we should adopt multimodal analgesia, especially preemptively. One thing that I also, one patient is capable of delivering his own dose of analgesia. I'm speaking about patient control analgesia or patient pumps. So please, let's try to give them that when they are capable of delivering. If not, then also the nurse can use the likes, nurse control analgesia, and be careful to set accurate ceiling, not to deliver overdose or underdose. Thank you, Sharif, and I'm so happy that you presented amazing presentation, and I'm so proud of you, brother.
Thank you so much. Any questions? From the Facebook?
In Facebook, no more question.
I think my idea to improve practice or to يعني like we are like anesthetists, we should to I think to fix nerve block techniques practice in intensive care units in Sudan. I think nerve block we can to add more multimodal anesthesia for the patients, especially according to problem of availability of drugs, anesthetic drugs, or sedative drugs, analgesic drugs here in Sudan. So one of the important issues to practice nerve block in intensive care, like analgesic procedures. Any question? مهند ما في question ظاهر.
لا ما في أزل.
طيب أنا أقول thank you for your attention.
Okay, next section. Thank you, Sharif.
Thank you, Dr. Vladimir. Thank you, everybody.